And then I'm going to go through the clinical application of non-surgical decompression, how it works, what the treatment plans are like, the patient outcomes, etc. I'm going to walk you through actually the MT core that we've got here. I'll show you how easy it is to set a patient up. And then we're going to go through any questions also afterward. We're really lucky. We've also got Dr. Stephen Kirby here, who's the owner of Chiro Launch, and he's an expert in marketing of this type of technology. He's going to speak to us at the end about how he's helped other clinics implement this technology into their practice and get it going as fast as possible and as well as possible for everyone in there. So yeah, so a little bit about me. My name's Jeremy. So I did my original master's in Sydney in Australia. I then travelled to Europe, and I've been working in Australia, South America, and in Norway and Europe for many years. I did my board certification in pain management in the US. I then also did my regenerative fellowship in regenerative medicine. I then did my fellowship in interventional spine management. Then I also did my advanced diploma in musculoskeletal ultrasound, and I'm currently doing my PhD in disc degeneration stem cell transplantation. After working for about 10 years, 11 years in Norway, I moved back to Australia about a year ago, and now I'm the clinical director of a practice up here in Townsville in North Queensland, called Townsville Spine and Sports Med. I still own practices in Norway, and we've still got non-surgical decompression in Norway. We're the first clinic to have non-surgical decompression in Norway, and we're the first in the Southern Hemisphere to have the technology that we're going to talk about today. So what I'm here to talk about today is sort of my role as clinical director at Vert Biotechnology, and why I got involved in the technology. Shinhwa Medical have asked me basically to come on board so I could help connect chiropractors and other healthcare providers with this technology, and so they could successfully and effectively implement this into their clinical practice and help patients in Australia, New Zealand, and the UK. The first thing that got me involved in actually non-surgical decompression, because I've been using a non-surgical decompression for well over 10 years now, was just when I saw that gap in the patient profile, the patients that weren't really good responders to manual therapy, weren't really good candidates for active-based rehabilitation, and didn't want surgery. And to be honest, their surgery doesn't have the best statistics. Where were we going to fit them in? What about the patients that needed movement but couldn't tolerate the loading? And that's what really led me down to try and find out, well, what other options are there out there? And then that introduced me to non-surgical decompression. The biggest thing with non-surgical decompression is, and it's very different to traction, we're going to go through that a little bit later, is how we can create a decompression event inside, whether a disc in the cervical spine or the lumbar spine, how we can actually stimulate that blood flow, so a hypervascularization event, to help restore vascular integrity and also some neurological space. I practice with the Hills DT, which is, in my opinion, the only other machine out there that does a comprehensive non-surgical actual decompression event. I was working that for about 10 years, and when I moved back to Australia and was planning on how to equip my clinic here when I was first starting out, it really led me down the line of wanting to think, is there anything more up to date out there? And that's when I really got introduced to Shinhwa Medical's equipment. I did have to travel all the way to South Korea to see the technology, because at that time, Shinhwa Medical worked primarily with university hospitals in South Korea and in Japan, and I'm more than happy at that time just to be providing their equipment, their technology to those types of facilities. Every machine is handmade. They still only have one factory. They have a limited amount of machines they can produce every year. And for them, one of the most important things is not having this in the hands of the right people, not just anyone. And that's because they really pride themselves on their name and the efficacy of their equipment. So the real world experience that I have from this, so I was just like everyone when they're first implementing new technology into their clinic, even though I had 10 years of non-surgical decompression experience, still outlaying a considerable amount of money or investing. It was a scary thing. I found that I was fully booked for one machine within the first 4 weeks of my clinical practice. I had to get a second machine, and I had to stop taking new patients from that 4-week mark. And I've got 2 machines now. We're seeing approximately 20 to 30 patients a day on between 2 machines. We're fully booked out. My biggest problem is that I need to implement another machine, but I need support staff around me. I need structures to be able to still maintain that level of care. And so that's what we're really getting to do. I have amazing reputation for chronic discogenic and complex disc and spine patients. So we've really adapted just in the year that I've been in Townsville to having a lot of neurosurgical referrals. We get a lot of DVA referrals. We get a lot of GP referrals as well. And even from other chiropractors and physiotherapists in the area, we get a lot of patients referred to us that have been non-responsive to active rehabilitation or manual therapies and go through there. So it's been an absolute wonder for my practice, and it was non-surgical decompression has always been a great bow to the technology that I've had in my clinic, and the Shinwan Medical, and particularly the MT Core, has really taken that to the next level. Why I feel like not every, but if you want to be the non-surgical spine specialist in your area, I think you should have a non-surgical decompression bench, because simply you are not going to have, we've all had patients that don't fit into active rehabilitation, don't fit into passive, that you're either non-responsive to treatment or in a way we're scared as practitioners to do it. We've all had that patient with a really chronic neurological signs, whether they be from the cervical spine into the upper extremity or sciatic and radiculopathies, that we've just thought, geez, I don't want to do any harm here. What do I do in this patient? I know they need movement, but either the tissue's too brittle or they're incredibly tight or they just don't fit into any of your current sort of hands-on treatment protocols. And throwing them on non-surgical decompression can be a great option for these patients. The whole point of every type of spinal treatment goes back to 2 fundamental principles. We need to create neurological space, and we need to create movement. Movement is what stimulates blood flow and the healing patterns. And so that's why when we're able to do that using technology, so we're taking out a degree of human error, it's just been an amazing thing to add for clinics. And I think that there's probably 30% of patients out there that are not getting treatment, if not more, purely because they don't have access to this technology. So what I'm gonna now, have we got any questions, guys? If you've got any questions, just make sure you put them in the comments and I'll answer them. Yeah, good stuff, guys. So what I want to explain now is what non-surgical decompression is. So non-surgical decompression is different to traction. The biggest difference is when you're doing traction, you're applying forces from externally and you're pulling, okay? Now, continuous traction doesn't work. All the studies really show that it doesn't work. And that's because we need a dynamic element. The actual movement stimulates the blood flow through the end plates into the annulus, and that's where those pain receptors really are. And when we think of it as a functional spinal unit, we know that creating that movement is what really stimulates the healing process. If you're doing a surgical decompression, that's where you may be doing either a laminectomy or a microdiscectomy. You are cutting away tissue to create space. And in this, we're trying to actually put the disc or the particular level that we're trying to focus on in a zero gravity environment. and mobilize it in through its physiological barriers, and creating that vacuum effect, which will create a hypervascularization and create movement, stimulate proprioception, and also work on lots of other pain pathways. What's really different with the Spine MT Core versus, or any of the Shinwan Medical's technology versus other models out in the market, is its three-dimensionality. So any other machine that's currently on the market, while being able to provide an axial decompression, which is important, none of them are able or have the degrees of technology where we can actually work in 3 dimensions. So what we'll show you later is the Shinwan Medical technology is actually able to create a 3D image and map whichever segment we've told it to focus on. It's able to then moving in 3 directions, or whatever's necessary, put it into an anti-gravity environment, and then depending on the tissues, adaptability and threshold, and on the patient's tolerance, it's able to work in through that, okay? It's able to adapt to whether or not we want to be unilateral. So say we want to just target the L5 left intervertebral foramen, we're able to actually do that. We're able to tilt to depend on if we've got a far lateral herniation or a more posterior central herniation. All of these things create a more effective treatment and a more comfortable patient experience. And the capture itself is completely unique. The Shinwan Medical technology has airbag captures, so it's able to really adapt around a patient to really give them a comfortable experience. When you're doing that, it means that we can use less force and we can be far more effective because we're not dividing those forces into other tissues, and the patients are far more relaxed, it's far more comfortable. So we're really able to bypass any of that muscular tension. The Shinwan, particularly MT Core, has an AI-assisted biofeedback. So when a patient's actually properly fitted to the bench, they then become one with the bench. The decompression is so different because it's actually happening directly underneath the segment, whether that be in the cervical spine or the lumbar spine, which means that the forces are essentially coming from within rather than pulling apart, which is why we get that really strong vacuum decompression event happening inside the disc, and mobilization event happening inside the facets as well. As I say, this has got AI-assisted biofeedback, and that's what's amazing with it. It's adapting to the patient. Each time it's recording, so at the beginning it will do a 3D map, a priming of the segment, a treatment protocol, and then a post-mapping, and then that's recorded into the computer. So the next time that patient's in, it will again check their baseline, compare it to what they were at last time. And so it's constantly adapting to the patient. So it allows the patient to be pushed to their barrier and continue to adapt without pushing beyond that. So in a way, we're taking it's controlled, it's reproducible, and it's extremely safe because of that. We're in a way taking a degree of the human element out of it, or human error out of it, so that the safety just goes through the roof. Any questions on non-surgical decompression, guys? Yeah. So who are Shinwan Medical? So Shinwan Medical is a medical biotechnology company based out of Busan in South Korea. Initially, this technology was designed by a group of 16 neurosurgeons, orthopedic surgeons, sports medical practitioners that all came together wanting to basically provide another solution for patients with chronic and debilitating discogenic and spinal arthritis. So they basically came together and tried to form what in all of their experiences was needed to help these patients, and that's how they came up with this technology. They are constantly adapting. They are absolutely the forerunner and the benchmark in the world with non-surgical decompression. They're constantly adapting. They've got constantly, even though each model may be saying very similar. As new sensors are coming out, as new components coming out, it's constantly they're improving. So even myself, this is the first one that was in the Southern Hemisphere. When we've implemented and we've set up the same model in other clinics, they've got even more upgraded system than us. All the machines are handmade, so they have that bespoke finish, and so each one of them is slightly different, but they're still continuing to adapt. What's that question? Sorry, I'm just going to read that question, guys. Cox flexion distractions, attraction. Yes, exactly right. So flexion distraction isn't really a decompression because you're just stretching out the tissues. We actually need to create a vacuum effect to actually have that happen. Yeah, so how you're creating, so the next question is not quite understanding how it's creating internal forces as opposed to external ones. So when a patient is actually is fastened to the machine is actually, the bench actually sort of makes them one with the machine. And because of that, it's able to, and because the drive shaft is not a pulley-based system, it's a drive shaft, it's able to actually function directly underneath the level rather than on the sides. Does that make sense? So the forces are coming from underneath rather than from outside. So that's why you're able to be a more direct sort of internal aspect of it. Does that make sense? Perfect. Any other questions, guys? Yeah, so height, are there any limitations with regards to size, heights? So not heights, not at all. It is extremely important that you actually that you measure your patients, particularly with their heights, because of the biofeedback. If you put a patient's height in incorrectly, the bench will be trying to find what is a standard L4 or L5 level. And if their height's incorrect, it will come up with a bit of an error message. So that's why I do it. There's a weight restriction of 150 kilos on the machines. That's the only thing I'll be saying. But height isn't a problem. We definitely find that patients that have a extremely high BMI, so are extremely obese, do take more treatments to show effect, but we'll talk about that a little bit later. Okay, so another thing is about support. What support's offered for machine malfunction? Talk about that later. Yeah, we will definitely go through what happens if you implement this into your machine, into your clinic a little later on. So we'll answer those questions, may even answer that on the way. Is there any other questions on non-surgical decompression, or have we all got a pretty good understanding of it? Great. So non-surgical decompression, we've talked about what that actually is. What we're going to talk about is the patients that this is going to be a great thing for. So I'm a single practitioner, and so when I've got a patient coming in my door, I'm basically assessing, is this a patient for manual therapy, active rehabilitation, non-surgical decompression, or referral, okay? And the particular patients that I put on non-surgical decompression are typically the patients that have either previously responded to manual therapy, but now aren't responding to manual therapy, or simply have really strong neurological compression, okay, or discogenic-based symptoms. This is not for acute care, so we never put an acute patient onto this. So basically, we're looking for patients that we know have discogenic pain, that either don't want manual therapy or have been non-responsive to that, or active rehabilitation, particularly if they've got any types of neurological compromise. So we've got nerve root impingement, stenosis, whether that be central or lateral. These are great candidates for it.
Subacute.
Yeah, we can definitely do subacute patients. So When I say acute, if this is a patient's first bout of back or neck pain, non-surgical decompression isn't for them. You remember 90% of patients will heal within the first 16 weeks, even if you do nothing. This is but for patients that have had previous histories of lower back pain, so they've had a chronic history of an L5 disc herniation, and this is an acute episode on chronic, then they're a perfect candidate for non-surgical decompression. I typically give this to patients that we need to create space, we need to create movement inside the disc, but we're apprehensive to do loading, or it simply won't tolerate loading, or that they're more neurological signs rather than biomechanical signs, i.e. their referred pain in their leg or upper extremity is far worse than their localized back pain. So it's a sign that their nerve root is more impinged. Then I would be prioritizing creating neurological space and hydrating that disc to try and create more room in the IVF rather than focusing on movement. Now, that doesn't mean that patients can't start in a non-surgical decompression and after the first phase of care become a manual therapy patient, or they can go to active rehabilitation. But those are the patients we use, and also patients that have more complex spinal arthritis. So severe degenerative disc disease, previous spinal surgery patients, a lot of previous microdiscectomy patients that have reduced movement because of the microdiscectomy. These are all great patients for this. We do a lot of cervical radiculopathy patients, whether that be because of disc or be because of arthritis. Cervical patients have an amazing success rate with non-surgical decompression. When it comes to care plans, we basically implement the same treatment protocols that they do in the neurosurgical departments in South Korea. So we just copy their protocols. Their protocols show for a phase 1, a minimal effective dose is 10 to 14 sessions. Now, it's really important to highlight that's minimum effective dose, and that's also a generalization of both cervical and lumbar patients. Now, we all know as clinicians, some people heal faster, some people heal slower, but that's to give us a framework. So we want to do that initial care in about 6 weeks. The reason why that needs to be done is because you need to create physiological momentum. After that first 6 weeks, then we will continue some type of rehabilitation plan, whether that be non-surgical decompression, for at least a 4-month period post, because that's purely how long those tissues take to recover anyway. So a typical patient in a 12 weeks to 12 to 16 weeks could have on average 18 to 28 treatments, depending on their patient tolerance, on their specific injury, and also just on their individual healing habits. So that's sort of the treatment protocols we do. It's really something that patients find a lot easier to buy into when you're talking about minimal effective dose and technology. It's like, when we know, right, it's technology, this is what they do in the neurosurgical departments, this is what's been shown by the literature to be the most effective. They don't tend to then think, they tend to just be far more agreeable to it, accepting. When you take out that degree of human interaction, so it's like, oh, can't you just do more on a treatment, or can't you just make this go faster? When you're taking that step back and saying, no, it's just like getting an antibiotic, minimal effective dose says, we've got to give you these 10 treatments, these 10 days. It's just a far easier treatment protocol. Questions, guys? You mentioned either or. Yeah, absolutely. So we just got the question, mentioned that when I typically see a patient, I'll be funneling and saying, is this a manual therapy? Is this a non-surgical decompression? Is this an active rehabilitation? Is this a referral? Yeah, of course. A lot of patients will, initial care, I might say, yeah, you're a great candidate for non-surgical decompression. We'll send you there. And then after initial protocol, they may find that their L5 radiculopathy has improved exponentially, but because of the chronic biomechanical overloading in their sacroiliac joints or hip joints, then they need some type of manual therapy to help catch those joints up to the mobility that we've created higher up in the extremities, higher up in the spine. So yeah, you absolutely find that you combine, and vice versa. You can find that you've got a patient that's got a lot of supraspinatus tendonitis and impingement syndrome in their shoulder. And as that improves, you start to notice they've got a lot more radicular pain from, say, a C5 disc. And then putting them on non-surgical decompression for their C5 suddenly starts to alleviate everything as well. So yeah, you often do combine. And that's why it's really important to highlight that this isn't a recipe book. It really needs to be run by a qualified practitioner that knows how to diagnose and knows how to triage. So this is just another tool to add to an already sort of competent practitioner. Any other questions, guys? No, great. So clinically, patients tend to love, particularly. So I've had a Hills DT, which is another great machine based out of a US company that does purely axial decompression, so just one directional. I've had that for 10 years, still have that in Norway. One of the biggest differences I found from that compared to this is just patient complaints. With the Hills DT, while patients were quite happy with the clinical results, you'd often have them complaining about how uncomfortable the session was. Either it pulled too tight in their ribs, or it jammed too high up on their neck, or it jammed into their hips because it's more of a pulley base. Because this has an airbag system that really adapts to each patient, patients just find it really, really comfortable. Because it's got that three-dimensional mapping, it really adapts to a patient. So it'll automatically sort of fit to the patient. It's sensing what's going on. And so it's always trying to create the most comfortable patient experience. Typically, we'll find that cervical patients have a much faster healing rate, and we have a higher success rate or highest patient satisfaction rate with cervical than lumbar. And that's purely because there's less forces going through the cervical spine. So clinically, we'll see anywhere from a 50 to 90% improvement in pain and function, with function always outperforming pain. It's really important that patients that we're putting on this, that we're explaining that, because this isn't, it's just like a manual therapy. We're not trying to band-aid or mask pain. We're actually trying to stimulate the tissue to heal. We're trying to stimulate the tissue that's damaged, stretch any tissues that are too tight, and stimulate or strengthen any tissues that are inactive, exactly like we've all been doing in our clinical practice, just this doing another way. As long as patients understand that, they're really well. And particularly this is effective with patients that are more concerned with their function, because as they get more function, they'll use their spines more, they'll have discomfort. As long as you explain that, patients understand. And as long as they understand that we're not doing miracles, and these things are manageable, not curable. Our success rates are our patient satisfaction rates for cervical spine is actually in the low 90s. So it means that 9 out of 10 patients that we have coming in that are good candidates for cervical decompression are super happy with their response. Lower back for lumbar spine, it's more like about a 75% success rate. So you will have one that's non-responsive, you'll have one that's sort of responsive, but the majority are really, you will notice some changes, whether that be a 50 or 90% improvement. That can be really dependent. I always like to compare. So my wife's a general surgeon and a urologist, and when you compare what we do in manual or in physical medicine compared to what's been doing in medicine, and we're sort of thinking that 100%. Realistically, my wife said if you can get anything at 70% success rate or patient satisfaction, you're a rock star. Yeah, question? Have I had any severe negative reaction, like a patient feeling worse? No. So I've never had a negative. I've never exacerbated the symptom, if that makes sense, because of the biofeedback that this is going. It's got a sensitivity that we as human beings don't have. So no, I've never had a bad reaction. I've definitely had, not in the cervical spine, in the lumbar spine. I've definitely had that because this has a sacral pump, so it's actually pumping the sacrum into extension as we're doing a decompression to mobilize that cerebral spinal fluid. You'll definitely have patients that, probably about 1 in 20, that'll aggravate their sacroiliac joints, and then they may have an improvement in their discogenic pain, but their sacroiliac joints may become symptomatic. We can turn that off, but that's probably the most common thing we get in about 1 in 20 patients. Cervical spine, no. The biggest thing is because it is constantly tracking and working within a patient's pain tolerance and tissue threshold, you don't really have, you have to say it's a possibility, but clinically we never see that. But we definitely see patients that are sort of like, I feel like it could go more. I feel like I'm just on the edge. If it could just push me a little bit further, and explaining to them that's the whole trade-off we have with this, is that it's tracking them. So it's not taking you beyond your threshold. It's taking you to your threshold. And that's how we also mitigate that risk of potentially making things worse. Good question. Anything else? I will say, so that is one good question. You will find that some patients may be sore, particularly for the first 4 to 6 treatments, if they've got a huge collection of scar tissue. So if you've got a patient that's had, for example, a microdiscectomy or a laminectomy, and you are mobilizing that area, you will have a degree of connective tissue, scar tissue. So you'll find that they'll get more like a DOMS type of pain post-treatment, and that can be for the first 5 to 6 treatments. It never is long-lasting, so it's sort of just transient. But as you're actually mobilizing, yeah, you can absolutely get that. But most patients understand that's part of the process. Do I insist on X-ray MRI before I do a care plan? So I'm going to tell you guys, I follow European guidelines when it comes to this. So I will only refer for X-rays depending on what I'm doing. If you want to rule out red flags, yes, you can do an X-ray. I don't insist on it. It's a clinical diagnosis. In a lot of patients I get, they automatically come to me with MRIs. I would refer for far more MRIs than I would for X-rays, purely because that's what I'm looking for. I would caveat that and say, having worked in the Scandinavian system for so long, where MRIs are covered, you don't do many X-rays or CTs when MRIs there. So that's what I recommend to my patients. And I'd only recommend that if it's going to change my treatment protocol, or I'm not clear on my clinical diagnosis. So I don't insist on it, and I understand each practitioner will be a little bit different depending on your degree of clinical clarity and experience. But no, I may use it to help me, and I would say probably 70 to 80% of cases I have access to an MRI or a CT. But unless I'm really unsure, I really want more clinical clarity, no, I don't insist that they get a new MRI or a new X-ray. What's fun? And what are the main contraindications? We're going to go through that, so we're going to get to that a little bit later on. Okay, so, and the other thing is, sorry about this, guys. Surgery. So when we look at the statistic of surgery, they're pretty pathetic, to be brutally honest. And so my 2 PhD supervisors, both neurosurgeons themselves and spine surgeons, they'll tell you basically, if the textbook for spinal surgery is this thick, the textbook for complication post-spinal surgery is this thick. And that's because, again, we want to create neurological space and movement. And typically surgery is a two-dimensional solution to a three-dimensional problem. We're either sacrificing space for movement, we're cutting away tissue, if we're doing a laminectomy, we're creating space, but we're weakening the structure itself. And the spine works reflexively. So when we're affecting one level, we're affecting above and below. So that's why this is a really unique way to address patients that otherwise would have just thought surgery was their only other option. Yeah. So now what we're going to do is do a little bit of a walkthrough of the features of just the MT core. So have we got any questions more on that? We'll talk about the contraindications, everything afterwards. Any other questions? No, all good. So what I'm going to do is I'm actually going to show you and put on our operational director, Jake, onto the machine. And I'll show you how easy it is to strap it on, and I'll talk about some of the features of it while we're doing it. Okay, guys?
Hello, everybody.
So it's super simple. We're just going to do a lumbar setup on Jake. Now, Jake has, all we can do is, so here is our interface. It's really easy to get to. Clicking this on, away you go. Now, what we're going to do is we can recall all of our patient's information. It's all logged in there. So we just go straight into there and we can search. We can find out exactly when he's been here. We can track. We've got the graphs. We've got everything about all his treatments. So we can just simply press apply. Everything's already pre-stored there from his last treatment. It's really important that we make sure that there's nothing covering. So there's no tissue, there's no tension with the shirt being tucked in. So the shirt always has to be untucked and the lower back exposed, and vice versa in the neck. So what happens is we simply have to move the patient up. The pelvic belt simply goes over like that. It doesn't have to be too tight. Like I said, this has all got airbags in it, which will adapt to the patient themselves. We've got a leg here, just to put the knees up. Now, this is something that'll go, everyone will be a little bit different, and it's really patient comfort. The thoracic just goes around the rib cage, just like that. Again, it doesn't have to be tight. Now, it does have another thoracic capture here that you can use on some of your bigger patients, maybe on your female patients if you don't want to use. It's up to you. These are the two most important ones with the lumbar. Now, it's got a safety lockout switch, so the patient can always press that. Now, the only thing that is manual on this machine, so that you actually have to do yourself, is the lateral flexion. So say if you've got a patient with pure unilateral symptoms, a right L4 far lateral disc herniation, what you can do is we can manually shift the bench to open up and isolate that IVA. Okay, now everything else is fairly automatic. It has an auto setting. So as it's doing its mapping, it's actually finding that. So you'll find that this part of the bench can actually tilt to help to isolate that nerve root that you're after, or if it's a lateral or a posterior or more of a central herniation, to adapt to that. And it can be one side more than the other. And you'll see that. So once the patient's set up, it's as simple as pressing start. So this is basically where everything is in. We can heat the table up. The time, all the research points to a minimal effective dose of being between 20 to 30 minutes. We clinically find that 25 minutes works out just perfectly. 20 minutes is possible, but scheduling wise, it's really hard to set that up. 25 seems to be a really golden number with patient experience and also practically implementing it into your clinic, okay? What we've got here is, like I said, there's a slideshow that's running up for the patient while it's doing its mapping area. So as you can see, it's tilting, it's mobilizing, it's trying to isolate. In Jake's case, the L5S1 segment, we've got the sacral pump going, so you'll actually be able to see underneath here the sacrum expanding just to create that extension through there. The thoracic mobilizing as well. This does have a manual setting. Shinwan Medical is working on a protocol for scoliosis patients where this can be actually used to mirror a patient's scoliosis and mobilize it sort of in the reverse of their scoliosis. So that's why you actually have to manually change to isolate the thoracic or the lumbar or the pelvic mobilization. But that's not what we primarily use this machine for. It's the decompression with mobilization. It's got multi-levels that you can continue to move through depending on intensity and on patient tolerance. So as I said, the first 3 minutes is spent 3D mapping, isolating, finding that segment, finding out the patient's barriers, finding out the most comfortable position to work in, and then it will do about 22 minutes of decompression, and then the last 2 minutes will be a post-mapping. Yeah, do the bells and whistles. Yeah. So if I just show you now, I'll just take this in just so I can show you all the mobilization. So you can see all the moving parts. We can, for example, so we can put the lumbar mobilization on. You'll see the lumbar segment move. We can then put the thoracic mobilization on. Good. And then we can put the sacral mobilization on and the pelvic mobilization. So Jade can actually feel his sacrum being moved up and down. And the pelvis is also tilting and changing. Is there any questions on the features of the table, guys? Okay. Are you able to leave a patient on it throughout the process unattended? Yeah. So this is when it comes to treatment protocol. I am in charge of all treatment protocol. I set it up. I journal on each patient, but I have my assistants actually strap a patient in. We actually have a little bell. It'll go off anyway. So if the patient presses the emergency stop, I have it all set up so that I have one of my assistants come in and check on the patient throughout the process. So yes, it is safe to do that. If at any time the patient reaches its threshold, it'll automatically cut out. What we'll try and do is if we can actually show you guys what it will look like, because the graphs that actually are showing the patient. So if I actually take this back to auto, what you'll be able to see is it's actually tracking the patient's distance traveled, time, and forces. And so it's actually tracking what's going on the whole time with regards to the tissue's ability to move, basically. It's elasticity. Patients are able to track that. They'll see it up here on the screen. So they're actually able to see the table moving. They're also going to be able to sort of ask you guys questions. What does it mean? Basically, you're only looking for the tissue adaptation. You'll find that even if you set the bench to do, for example, 52 kilos of force, and it finds that the patient's not tolerating more than 40, it'll only do 40. As long as it's nice and smooth, that's fine. It's basically, it's got an sort of an auto safety on it that won't go beyond anyway. Good. And then when getting a patient off, again, this is something you can have your support staff do. Super easy. Take him down. These all swing out so the patient get out. One thing is very important is that when they've been in an anti-gravity decompressed environment for however long, a lot of patients in their first few sessions will be sort of loving life because they've got no radicular pain, feeling really good. They'll stand up, and that initial pressure onto the disc, patients will sort of not like it. That probably happens to me once every 3 weeks. So maybe 1 out of 250 patients. will experience that, and it's simply just allowing them to relax down for another 3 to 5 minutes, slowly get up, just allow their tissue to adapt. So this is more a transient side effect that's negative sometimes. The cervical capture is very similar, except we have a wheel-based system that we can put the patient into. The thoracic is what mobilizes there. And again, creating lateral flexion is done like that. Again, because of the AI-assisted biofeedback in this, it's the intuitive technology basically adapts better than you do. So I would very rarely be doing the lateral flexion, only if I've really got a unilateral side disc or radicular symptoms. Have we got any questions, guys? Does the table select specific? Yes, it does. So up in here, you can select the particular level you want to focus on. And like I said at the beginning, because you have to put in your height, your weight on each patient, it'll actually specifically try and track and find that so it can focus in on that. Now, one of the biggest features or the biggest flex that this technology has is that it's multi-directional. There's no other systems out there in the market that are able to actually move three-dimensionally and adapt to a patient. So every other machine on the market is purely doing an axial decompression. This is the only technology that's able to do an axial decompression and a mobilization in all the planes to create that more bespoke experience and really the most and allow a more adaptable treatment for practitioners and for patients. Now, does anyone want to see a cervical setup as well? Just write in the comments if you want to see a cervical as well. Yep, so we want to see it. I've got a question. Is this a means to say sort of feels the tissue resistance? Yes. So in a degree, yes. So because once the patient's actually properly strapped into the table, it's like the patient has become one with the table. So it's sensing the movement the whole time. So if there's any type of apprehension, it's going to be pausing and trying to either work through that or not go beyond that. Okay, so now I'm going to show you the cervical capture. Super easy. So we've got two of the captures in here. You'll see they've got Velcro in there. This actually, and padding, this changes. It's really important to note that all of the actual sort of, what would you say? So the anything that can fatigue on the table, for example, the straps, they can all be replaced very easily. Everything else with regards to the machine and the technology, they've had these in university hospitals in South Korea, seeing literally hundreds of patients every week for more than a decade without any problems. The South Koreans in Shinhwa Medical, their attention to detail and quality of work is absolutely second to none. What you do is it's simply adding these two in, and this actually goes in and out. So unlike anything else that just has sort of slots, this has the ability to change to specifically adapt to a patient and their head and neck space. So I'll just have Jake come in again. Again, this time it's not as important, but it's still really important to make sure that the skin is exposed so we're not getting any false readings of tension because of flow tension rather than tissue tension. Again, we're putting this around the iliac crest, around the thoracic and ribs. We're setting this up so the patient's nice and relaxed. Now, what we'll be doing is we're trying to get one finger just between the nuchal line and the padding there, and then basically letting that come out to where the patient feels comfortable. How this then goes is it has a cushion that goes directly over the forehead. It goes down. Now, I do use a tissue with each of my patients just to put over their forehead. Once it's there, it's simply brought down. Now, you'll find that then all we have to do is switch to the cervical setting. And then what we'll do, just for this intents purpose, we'll just add on traction. We'll just add on thoracic mobilization as well, okay? So what we're going to see here, we've got it to target, sorry, I'll just get it to target more. So we've got it targeting to C1 to C3. We do a typical C5 to C7, which is far more common. So what you'll see is it's actually now trying to target and find out exactly where C5 and C to C7 segments are. And then you'll find that it's using the thoracic mobilization to try and find his range of motions in there. And it's mapping up on here. So this is getting real-time feedback the whole time. You can see it's mapping from this side rather than this side to try and find out his range of motion, his tissue tolerance. What's this? Yeah. And as I said, it's adapting to whichever angle we're putting it on. Now, you cannot do both a cervical and lumbar treatment at once. It's not recommended, and you can't do it anyway. What you can do on a cervical patient is do a sacral mobilization, so you can get that cerebral spinal fluid pump, but you can't do a lumbar decompression and a cervical decompression. I typically don't suggest that you do that anyway. Just with doing sort of following through with treatment protocols, I would only do a cervical protocol first. And even if a patient's got, a C5 radiculopathy in their neck and a chronic L4 discogenic pain, both of them may well be great. Both of them may well really respond well to non-surgical decompression, but this is such intense treatment, specifically focused around creating neurological space and movement, that once you start trying to do them both, it's kind of like you're diluting the effect. You're sort of chasing pain around and you're not really following through a treatment protocol. And in that case, again, there's no hard and fast rule, but I would choose one, do a full treatment protocol on that, and then do a full treatment protocol on the other one. Patients, as long as they understand that that's what they do, typically they'll get through to around that 6th to 8th session and be saying, oh, my neck's feeling so much better. Maybe we can start my lower back now. Sorry, guys. It's like, remember, this is like stopping your course of antibiotics after the 4th day when you stop coughing. You've got 8 days of antibiotics, follow it through, so we finally get rid of it. And that's how we'll deal with this. As you can see, it's still mapping. You'll see very shortly it actually starts going to its protocol. So we've got a question, would you adjust then use this same day or patient vice versa? No, I wouldn't. I may well occasionally, if say I've got a patient that's come in with that we're treating a C5 disc, and then they've come in with a mid-thoracic, but this isn't an adjunct, and so I might do a mobilization of that, but this isn't sort of for every patient. This isn't just another adjunct. So this is a treatment modality itself. So I would tend to say if a patient needs manual therapy, for example, for a sacroiliac joint, and they're also getting treatment with non-surgical decompression for an L5 disc, I wouldn't do them in the same day. I might triage to do 6 decompressions and then maybe 2 weeks of manual therapy and then finish off the rest of the decompressions. But no, I typically wouldn't do them in the same day. And again, that's because we want to keep a clear treatment protocol. So we want to make sure that we're limiting the amount of variables to make sure that we're tracking them. Does that make sense? Any other questions around this, either the cervical capture or the lumbar capture, or anything else we've discussed with the features of the MT core? Just write them in the comments. You asleep yet?
I know, I love it.
You will find that particularly with cervical patients, the sort of more elderly stenotic patients, bone on bone, massive facet arthritis, massive degenerative disc disease, bilateral radiculopathy, you put them on this and you'd be lots of patients that you'd be very apprehensive to manually adjust, either because they might be osteoporotic or of course, severe osteoporosis is a contraindication to this, but, they may be old and brittle, and you pop them on this and they fall asleep and the ridiculous symptoms disappear and they have the best 25 minutes of their day/week. Responds really nicely. As you can see up here, this is where we're tracking. So this again is the distance traveled, this is the time, this is the forces. What you can see is sort of the forces as they're intended, and you can see the actual patient's baseline. So this is what it sort of maximal should be, or this is perfection, this is where they are. It doesn't really matter. Like it's not a competition to make sure the patient is exactly like that. It's purely there to show the patients that the feedback that's going. They can see it up here as well, so it allows them to see what's going on. As I said, this will then go, and then after it's done with its treatment protocol, it'll come back in, and the last 2 minutes is spent doing a post-mapping of treatment, and then that's stored in here. On the Spine MT core, it's all stored, it's all put on here. With the TheraMaster, it's an analog-based system, so you have to record it yourself. It's still extremely effective with the treatments that you've got, and also has a infrared capsule around the lumbar spine. The K2 also has these features with a couple of extra. It's just got a little bit of a bigger footprint. Also has slightly different armrests, and also this cervical spine can actually be put into extension. So that's able to really help patients with real forward head carriage or predominant forward head carriage to be able to extend them out and then decompress them. What's the next one? Can it identify? Yes. So I've just got to think, can it identify any changes in patient's tissue compared to previous treatments, or to track movements, improvements, and so on? Yes, it can. It's all recorded in here. So you'll find that maybe their rotation's gone from 8 degrees on the right to 15 degrees on the right, and 10 degrees on the left to 12 degrees on the left, and also that they're actually getting better tissue tolerance. I said, what's the content of the post-mapping? What's the recording? The range of motion. The patient's tolerance, their physiological barriers is what it's recording. Yeah, and on the graphs, it's obviously recording the tissue tolerance. So it's recording patient's apprehension, their ability to accept the loads, basically. Great. Otherwise, Jay's going to go to sleep, so we'll stop that in there. We got any more questions, guys? Just write in the comments. So you'll hear it comes in and it makes a beep, beep, beep sound. The same thing, one of the things that I would say often happens with a cervical patient is that just when they've been in that zero gravity environment, they can get a bit of a head rush when they first get off the machine, particularly if it's their first couple of times. That's something that happens rarely, but it does happen. Most of the time, not so much. Contraindications wise, so basically the biggest contraindications you've got is active red flags in the area, so bone tumors. We've got a big list of the contraindications, and also too, guys, we'll be sending you guys the learning modules as well. And all the research is also available in the links, so you can have access to that already. Basically, you don't want to be putting any patient, you don't want to be targeting any levels that, for example, have hardware in them. So if they've got an L4 fusion, there's no point in targeting that L4 fusion. Yes, it is safe to target the L5 or the L3, but of course you can't target a segment that's fused. Yeah, active cancer in the area, severe osteoporosis. All these things are actually in the guidelines, and we'll send that to all of you, so that'll be available. One thing that I would say is that you can do, if this patient would tolerate movement, you are a good candidate for it. So spondylolisthesis, yes, that's fine because you're not actually putting loading through the spondylolisthesis, but you are able to address the discogenic pain those patients may have. Facet arthritis, degenerative disc disease, radiculopathy, absolutely, all those types of things. How much to charge? Now, I have a flat rate on my fees. So basically, I charge the same as I do for a manual therapy session or a non-surgical decompression. I charge exactly the same, purely because I don't want patients to think that there's any sort of financial incentive for me to be recommending one treatment versus another. So that's why I just do exactly the same. So I charge here $79. In Australia, currently they're charging anywhere between 79 to 119. Some of the Korean subcontractors or South Korean are charging about 100 US per session, and in Hong Kong it's about the same. So anywhere in that sort of price bracket is what's being charged. Any questions on that, guys?
Different cost, yeah.
Yeah.
Where's Dave?
So, David, is that cost what we're talking about? Are you talking about treatment cost? Oh, a machine. So that's a really unique question. So because each machine is dependent on the country it's in, because each country has a little bit of a different requirements of it, it varies from anywhere from 30,000 US up. That's all being available. If you've got any questions on this, Jake, our head of operations, will be able to answer all of that. So we can get that to you guys, no worries. Now, should we invite Stephen?
Yeah, get Stephen in.
So what are we gonna? We got another one. Hold on. Is there any being used in Australia? Yes, you're seeing it. So yeah, we've got two machines up here in Townsville. We've got now
12.
we've got 12 in Australia. That considering we've only been able to bring these into Australia since October last year. Yeah, so we've got 12 working in Australia since October last year. So yeah, there are some in Australia we're getting worked out. Any other questions, guys? So now, guys, what I'm going to do is I'm not a marketing expert whatsoever, so I'm going to let Dr. Stephen here talk a little bit more about how he's helped some of our partners that have introduced that technology, basically get full lists of happy patients.
Hey guys, so Dr. Stephen Kirby from the Chiro launch. I've been working and helping chiropractors since 2016. We were some of the first people to run Facebook ads in Australia back in 2014, 2015. And what I've seen, at least, I can speak to the difference between, 80% of our clients are in the United States. And in the United States, spinal decompression and other modalities like neuropathy are quite large. And if you're trying to create any sort of uniquity within the market, or you're wanting to stand out from everyone else, it's a complete blue ocean when it comes to Australia, New Zealand, the UK at the moment when you're talking about spinal decompression. And especially when you're talking about machines like this. Like in the States, they've got machines to this level, they've got Hill, they've got DRX, all these other, machines that cost, 150,000 USD. And all these different machines do obviously different things. But the price point for MT Spine, from what I've seen, for their ability to create that sort of reverse inertia that he was talking about before. There is nothing else really comparable, and it's very different to the old school, traction machines or the belt driven, spinal decompression. From a marketing or from a business building point of view, not only when you put ads out there or try to get attention for this sort of stuff, there really isn't many people out there for them to go to. You've got people that are using sort of manual or even automatic traction tables that just they can really exacerbate things, or they've got lower quality sort of spinal decompression tables in their practice. So something like this, I've worked with a couple of well, I think it's just Rob, I think in Australia. Is that right,
Yeah.
guys? Rob. He is up to something like 60 visits after 2 weeks or 3 weeks, or 60 consults on one of the tables. And I think he's either already ordered another one or is ordering one. He was telling me the other day.
Yeah.
So you guys can get really busy with this, but the unique proposition from not just from a clinical side. I mean, Jeremy's talked about all of that. Obviously, you can get great results with the patient, but from a business point of view, I think you'll all agree that it's very difficult to find chiropractors or chiropractors that can come in as an associate to sort of leverage yourself. And so a lot of us are sole practitioners, or we may have other practitioners, but essentially we've got that job, right? And something like a table like this enables us to leverage ourselves, whereby, yeah, we can be there to sort of clinically, point the patient in the right direction, but you can have a tech CA or a CA, put them on these machines. You might have two in your practice, and that's running, and you're adjusting, in another area, and you're able to get results for these patients and get referrals from doctors. Doctors really love this stuff. I've got a practice that I've been working with for the last 7 years in St. Albans in Victoria. They've got spinal decompression. They get anywhere from 5 to 10 referrals from GPs just for the spinal decompression. So if you're looking at, taking the practice to like a space, or you're thinking about, oh, do I get an associate, do I get an X-ray, or do I get, if you're wanting to really leverage yourself, I think the opportunity at the moment is quite large, especially in Australia, New Zealand, and even the UK. There's not as much out there as what there is in the United States. And to see how many of these practices that we work with in the United States have grown just by having this sort of stuff in their practice, I think it would be a very good idea to start looking at some of these and be at the forefront, just like we were with the Facebook advertising. And now, everyone runs Facebook advertising now, but back then it was a tough gig. People were telling me not to run ads and all sorts of stuff. So happy to answer anyone's questions from our experience of running this sort of stuff for people in the States and even here. Or if you have any other sort of business or marketing style questions towards, implementing this and what sort of numbers you might be able to see, happy to answer. Open the floor. There's only a few people with their faces up, but I'm sure everyone else is there. I don't know. I'm just guessing. But fire away, guys, if you've got any questions.
Yeah. If there's any operational questions as well, feel free to answer them now. The machines come with a 1-year warranty and a 2-year parts. As for functionality and tech faults within the machines, we haven't seen any of these machines being operational for over 10 years in different countries. There's never going to be any big major breakdowns with the technology. If there's ever going to be any faults, it's going to be with the system, and they're really quite simple to resolve. Shinmon Medical can get direct access, so these can be connected to the internet, and you can get direct access to the machines where they can be automatically updated, and they can do that virtually.
Yeah, I just want to say that thing, like Stephen said, it was exactly right. Like, I am a single practitioner, and that's by choice, because it is something that dealing with associates, dealing with everything that comes along with having more staff, building a practice that then, you're relying on other people, just it adds a huge degree of stress. Whereas adding a technology that can treat patients while you're in the other room, making it, you can, just like Stephen said, I'm suddenly able to see like 12 patients in an hour, and each one of those patients would not think that I'm a high volume practitioner, because they're all getting at least 10 minutes with me, because I'm able to leverage myself and my team and use technology to fill in gaps in my skills. And it's easily doubled my income.
John, just to get back at you for that, mainly interrupt. So Facebook is a big one. SEO is also another one. That's a longer term play. But because the other thing with this is that with chiropractic, your target, you're more of it's a geo-targeted area to maybe 15 miles, or 20 kilometers or something like that. What we find is that people will go further for spinal decompression treatments. Right. So if you're in a bigger city, you can use SEO and target a larger population. Hope that helps. Decent number of okay. Differentiate between. It's so Steve, so how do you differentiate? You can always differentiate through marketing. Like, there's way more chiropractors in Melbourne than there is people who have an acupressure machine, as an example, in the UK. I had this recently with a client who was trying to tell me that the Dubai was oversaturated with chiropractors, and there's about 50, and there's 4 million people. There's always a way to cut through the noise, basically. So you'll always be able to get heard. It's more about, being in front of people and being consistent. What we do see, look, the UK, even for chiropractic, lead costs are quite low. But especially for a treatment like this, it's very easy to get patients in. You're not going to have an issue with that. And the differentiation is going to be once they come into your practice and they see the results, and obviously referrals from there as well. Sam, curious for the marketing. I imagine it's yes and no. Like, it is revolutionary because, like, all the marketing, it is something completely different. So once they see, so as an example, we have different videos with people getting treatments. We might have different static images that grabs attention. It's a lot easier, and for some reason, humans really go for technology over other humans, right? They really do. So when you're trying to get someone to understand or get some sort of treatment, if they've got if there's a technology, they'll go for that over trusting another human. So even from a selling point for you as a practitioner within the practice, it's easier to sell them onto a package with a technology than it is to sell chiropractic, if that makes sense. I think it's always been the case that humans trust technology, Sam. Like, yeah, it's one of those things that they do tend to trust technology over, over other humans telling them that we're going to be able to get you a result. And it's always been the case, even in practices where I've seen, new grads that really struggle with getting people under care with chiropractic. When it comes to, spinal decompression or some other modality like shockwave, they can kill it because it's not them that they're selling, it's the technology. Is that me, John? Are you wanting to talk? Yep. I can get the guys to get you my information if you like. I'm also on Facebook. If you look up my name, I'm happy to chat. Yeah, David. Yep, definitely. I can show you Dr. Rob's results with MT Spine as well, and give you an idea of what's happened there. But I'll get Jake to send my details across. More than happy. Is there any other questions from that angle? You guys can talk too, like you can jump off mute. I think the guys are happy for you to do that if you want. We can create a bit of a chat.
Yeah,
Instead
go
of
ahead.
these messages. I feel like I'm talking to myself and
Yeah.
Jake, how are you?
Good, mate.
Goes far away, guys. Like, let's have a conversation if you want before we end up. I'm happy to do that.
I'll say, like, I couldn't agree more. Like, patients, I've literally had patients come in and say, I hate chiropractors. I swore I would never go back to one, but my neurosurgeon sent me here. And then after doing non-surgical decompression on them, they'll refer me like 4 or 5 other of their friends. And like, they'll in the waiting room go, I hate chiropractors, but the bench is awesome. And you just go, no worries. And that's the greatest thing, because like, they're basically saying they hate me and then paying the bill and telling me everyone how shit hot my clinic is.
Can I tell you guys that most people in the States, they don't have their practice name for spinal decomp the same. So they'll call it Disc Center of Winnetka or Disc Center of Florida or whatever it is, to differentiate themselves from chiropractic. And in part, it's for referrals from different medical fraternities, but also they may have been to other chiropractors and not had a result. And so they differentiate themselves as well a lot of the time, is what we've found.
Jeremy, can I ask a question? Can you hear me?
Go for it, David.
Go for it, Dave.
Oh, thanks. Okay, cool. What was the you had phase 1? It's about 10 to so many treatments for the first, how long was it? And what's the phase 2?
So what you want to do is the initial minimal effective dose is 10 to 14 sessions to be conducted within a 6 weeks period. So I'll tell a patient, yeah, basically that's what they do in the neurosurgical departments in South Korea. So we just copy that, and that's what their research protocols really point to. So initially I'll say we need to do an initial phase of care to create that physiological momentum. That'll involve 10 to 14 sessions within a 6-week period. Then we'll do a reassessment. The tissues that we're addressing are typically tissues that take 24 to basically 4 weeks to 16 weeks. So we'll be tracking a patient throughout that whole 16 weeks period. So while phase 1 might be 10 to 14 treatments, phase 2 over the preceding 6 to 8 weeks could again be another 6 to 10 treatments to 14, depending on the patient's tolerance and progression.
Okay. When you reassess, do you do like MDRs, like muscle dermatome reflexes, and measure that stuff?
Yeah, so I'll have a tag test on every single patient, whether that be an SLR, whether that be a compression, a Sperling's, whatever my tag test has been. I'll conduct that probably every 6th treatment anyway, but then I'll have them in. And then a lot of these will be subjective findings. So, for example, if I've got a really stenotic patient, like a plus 50, a plus 60 with central stenosis due to, L4 and L5 degenerative disc disease, and, they can't walk more than 20 meters at week 6. How long are you walking? I'm walking for 20 minutes a day, no pain. Great. Let's then see how you respond. We'll do 1 treatment every fortnight for 6 weeks and reassess where you're up to there. Oh, and after 6 weeks, I'm up to walking 2 hours without any restriction. I'm sleeping in bed. Great. That's perfect. Let's review in a month. You've had a month and it's started to slip back a bit. I've started to get a little bit tighter. Great. Well, let's set up a review appointment in 4 weeks' time, check that progress, because this is a manageable, not a curable condition. And so we've educated them on that. Now, that being said, there are some patients that they get to that, let's say their 14th session. Let's say they get to the 8th session, complete resolution of pain, no ridiculous symptoms, let's say in their cervical, like down C5, C6. I might then say, great, we'll let you go away and I'll see you in 4 weeks. And they come back and it's doing great, fantastic. We'll do another one in 4 weeks. Great, you're at 10 sessions. It's been 3 months, complete resolution. I'll see you for a 12-week review. Away you go.
Oh, great. Yeah, cool.
And then also on the flip side of that, there may be some patients that you get through that, 14 sessions, and they're like, I'm functioning better, but I'm really sore. And then you'll say to them, well, let's give you 4 weeks off to basically let your body heal and catch up. And then we'll do a reassessment and see then what's happened. And they might have 4 weeks to just heal, and then might come in, and then I might give them another 6 sessions because they're like, oh, it's much better now, but I felt I've started to plateau a little bit again. Great. Well, let's work on doing those sessions to get you through that cycle.
Awesome. Thank you.
Any other questions, guys? Now, it is important to note that I will send you guys, if you just reply to the email, is that right?
Yeah, send the email.
Yeah, if you send us an email. So we've got 7 modules, and we've got 5 of them learning modules completed. So first module is on the anatomy and physiology of the functional spinal unit. The next one's on a introduction to degenerative changes of the functional spinal unit. Third one is modules on management strategies, so the referral pathways for spinal degeneration. Then we've got also a module on non-surgical decompression, the why, which is going through all the benefits to review how it physiologically and biomechanically works. Then the 5th one is also on non-surgical decompression, the how. So we actually walk you through the treatment protocols. So if you guys just send us a message, we'll send those modules to you guys. So we've really tried to put sort of 4 years of specialist disc experience and learning into these modules, so you can really get the get a crash course and make you the non-surgical spine and disc expert. Great. Well, thanks, guys. I really appreciate you guys coming in on a Sunday night. Stephen, thank you so much for the insight. You're a gun. We all know that. And if anyone's got any more questions, let us know. And we're really excited to help you guys in your non-surgical decompression journey and clinically, and just keep us in the loop. Okay, guys?
Nice to meet you all, guys. Have a good night.
Thanks, everyone. Bye.
Thank you. Thank you. See ya.
Bye.